Hi, everyone. Welcome to Doing Sociology. Today we have with us Professor V. Sujatha, who teaches at the Center for the Study of Social Systems, Jawaharlal Nehru University. She specializes in the fields of sociology of knowledge, science and technology studies, and health, culture, and medicine. Her report on traditional leather artisans highlighted the trajectory of communities that practiced vegetable-based leather tanning, and her book, Health by the People, published in 2003, analyzed the significance of uncodified medical knowledge in Indian medical traditions. In the book, Sociology of Health and Medicine, New Perspectives, which was published in 2014, she has sought to bring medical pluralism into the theoretical ambit of sociology of medicine. Her subsequent research on liberalization, food, and nutritional science engaged with health transitions in India and South Africa. More recently, the special journal issue that she has edited, Globalization of South Asian Medicine, Knowledge, Power, Structure, and Sustainability, examines global flows of knowledge and medicines based on her fieldwork in Europe. Her latest edited volume titled Global Capital and Social Difference, which was published by Routledge in 2020, brings together collection of articles that propose alternative perspectives in the theorization of globalization. And today she will be talking to us about body, health, and society. Welcome, ma'am. Welcome to Doing Sociology. And we feel particularly happy to have you with us because you've been a teacher to us, taught us at JNU. So welcome on Doing Sociology.
Thank you so much. It's my pleasure to be conversing with you and on this theme, which I think should receive greater attention in the Indian context. So I'm really happy to be talking to you.
I'm to start off our conversation with you. Do you think there is a need for a specific sociology of health and medicine in India?
Not exactly. Sociology of health and medicine has to it has not specifically for India, but it has to have a special wing or a special branch to be able to address societies characterized by medical pluralism, where there are other systems of medicine, traditional medicines, and coexisting along with a well-established biomedical infrastructure. So hitherto, sociology of health and medicine emerged in response to biomedicine, or what we call allopathy, and it emerged as a critique of the biological reductionism of biomedicine, and has always interacted with biomedicine. In fact, I use the term that sociology of medicine, sociology of health and medicine in the mainstream has been the alter ego of biomedicine. Like it tries to pitch in for the lack and what are the things that biomedicine misses out by focusing exclusively on biology with regard to health. But, whole range of societies, Latin America, Africa, Asia, and many countries of South Asia have their own traditional systems of medicine and a whole range of other medical practices at the folk level, tribal health practices, which continue to exist well into the 21st century. So sociology of health and medicine has to reckon with the fact that there's not just one monomedicine, but there are many medicines, and it at once opens Pandora's box. It makes the task of sociology of medicine very challenging, because if you just thought and interacted with one system of medicine, critiquing its structure, etc., it's one thing. But there are many systems of medicine. They have different perspectives on the body, how people resort to these different systems of medicine, what is their health behavior like, what is the power dynamics between these systems, which system of medicine adapts to the market, what are the products they produce, how do they influence the way people think about health and disease, and what is the kind of training. I mean, there's so many questions that medical pluralism can throw up, and which sociology of health and medicine will have to address. And in that respect, I do think that and it has been my effort to bring medical pluralism into the ambit of the theoretical formulation of sociology of medicine, because we need to have a new vocabulary. We need to have new concepts to address this interplay between systems of medicine. And there are a whole range of practices outside the radar of the state and the market. You might have seen the tents in many cities where they sell medicines for male potency. They make good money. I mean, there's so many things happening which we may not catch our attention, which is outside the mainstream. I call them social institutions of healing and health. And they do play a very big role, and they also are commercialized. So we have to look at this and see what connection they have to society, migration, new kinds of health practices, and how very contrasting health beliefs and practices coexist within the same community or within the same person. It's a matter of great sociological interest, I would say.
So, Professor Sujatha, could you also talk a little bit about the importance of the body in the sociology of health and medicine? What exactly would be the relationship between the body, health, and society?
Yeah, see, when we talk about many systems of medicine, sociology of and adapting sociology of health and medicine to medical pluralism, I think the body in medicine is a very good starting point. And in that way, we can also distinguish and go deeper than public health and community health studies, which are also looking at questions that I just mentioned. So sociology, by taking up the theme of body and the body in medicine, can go very deep into the understanding of medicine and medical systems. In fact, body in medicine is a subtopic or one aspect of the larger exploration in body and society. I want to mention here that mainstream sociological theory has ignored the body. After Marx, he's the one person who spoke about the laboring body. He spoke about men's relation to nature and how through labor, the body itself, I mean, Engels wrote about evolution, the origin of the transition played by from ape to man and the part played by labor. But in Marx's own writings on capital, industrialization, etc., the labor process and the fact that the body as a part of nature, working on nature, is very, remarkably present in the writings of Marx. But subsequent thinkers have developed an over-socialized view of social action. So the biology or the body is completely out of the picture in the social systems and other perspectives. So I think it was the feminists who brought the body back into theoretical discourse, because they said there's no universal action. There is no actions are unmarked. They are all marked. The body is very much present there. So you have phenomenologists contributing with the concept of embodiment. They come from a different perspective. So what I'm trying to tell you is that body and society is a fertile ground for inquiry. Even within sociology in general, you can address caste, you can address gender, you can address race and class, and thinkers have done it. We have to do it even more a focused manner, because body and religion, body and sport, body and performance, dance, music, etc., body in relation to space, these are all beautiful themes to be explored. And in this spectrum of concepts, I would place body in medicine. It's a very important theme, and it will help us straddle over many systems of medicine and theoretically enrich sociology of health and medicine. For instance, if we start thinking about the body and different perspectives of the body from systems of medicine, biomedicine has a particular understanding, anatomical and physiological understanding of the body. But a whole range of other systems think of the body as consisting of many sheets, many layers. So your body made of flesh and skin is the flesh tissues is only one, muscles. But there is also within our body a channel through which the breath, in Indian systems, they call it prana. And in other South Asian and Asian systems, they have their own terms. I mean, it's not something very specific to India. It's it's found throughout Asia, such a conception of the body consisting of hollow channels through which our breath passes. And that has been the basis for a whole range of martial art traditions, not just breathing. Your pranayama yoga is one part, but if you look at Kung Fu, Tai Chi, and all kinds, a whole range of Asian practices of the body, both martial arts and medical practices, acupressure, acupuncture, they are all talking about nodes and meridians and points. So this itself opens very new, interesting concepts about how you understand the body in different systems of medicine. Also of great interest to us is, does the way medicine deal with the body very different from the way the religion understands or deals with the body? Religion prescribes certain disciplines of the body, some fasting, you have to control your desires, you have to behave in a particular way. Certain disciplines are imposed, and Foucault has written about sexuality and the body. And interestingly, Foucault made a remark, I think towards the end of his life, he had an occasion to travel to a Buddhist monastery. And he mentioned, he found that to be very different. He said, I've written a lot about Western discourses on the body and, power, subjectivity. The East is pretty different. The silence also has meaning, and he says, in the way body and mind are connected. So coming back to the point I was trying to tell you, is that it's not that the body in medicine can be thought of in an isolated manner. The way religion thinks of the body, religious beliefs also, there is an interaction. Sometimes medicine accepts it. Sometimes, medicine would say the extreme, privations and deprivations of the body in religious practices are not good for health. That kind, so similarly, you have in sport and martial arts, if you see people push their body to the extreme limits, no ordinary person can do that much running, trekking, or wrestling, or bodybuilding. It's not a normal body. So there's a whole, every culture, whether modern, Western, any culture, it has a notion of the ordinary and everyday body, which all of us, we do and maintain a certain level of physical activity. But today, you see, you have to run, you have fitness, etc. Or the sports person, they are always constantly practicing. An extraordinary body has to be created where there's constant practice. And if you stop the practice, they can't succeed. Now, what is the role of medicine in sustaining this extraordinary body? And if too much of emphasis on fitness, does it actually go against health? So the concept of the body in medicine is not isolated. You can see it in connection with religion, with sport, with performance. So again, it gives us a very fertile ground for thinking. And all of us will appreciate that these days you have so many new disciplines of the body. They emerge from biology and biological sciences, but they have now created their own ground with new professionals, for instance, physiotherapists, nutritionists. The whole beauty industry is drawing from medicine, and it is, medical practices, surgeries, body sculpting, whole range for drawing on objectification of the body, the way the body should look, and a lot of consumption around bodybuilding or body shaping, body image building in a particular way is there. So these disciplines are neither fully part of medicine, but they draw heavily on surgical and other techniques that have developed within medicine. Today, you can't separate cosmetic surgeries from real surgeries. In the sense you distinguish, what I'm saying is a lot of surgeons would like to do cosmetic surgeries and they earn more in these fields. So medicine, you can say medicine has spilled over into other fields. And if we start looking at what kind of body, I told you about the extraordinary body, what kind of body does a particular society foreground? A couple of decades ago or earlier, maybe a saintly body, or an emaciated body is seen as saintly. Then you have slender bodies, or you have different. But today, I think the body has been objectified not only for women but for men, and so you have a six-pack body, or the wrestler's body, or a sportive body that is becoming the icon of the body everywhere, isn't it? Everybody, and especially after the COVID pandemic, this fitness has become such a big preoccupation, and it's no longer the slender or fragile body, but it is a fit body. The sportsmen, the celebrities, they have created this icon, which everybody aspires to do. So if you go to the gym in Munirka, you can see everybody holding a protein drink. We don't know what the consequences of all this is going to be. But tier 2 towns in India, everywhere, they are catching up with this particular kind of the body. So I think we should look at these crossovers, and that medical practices can have these kind of impact on larger society by promoting certain body images. But I should tell you that while we talk about body and medicine, there's one very important kind of theme that has been worked on in sociology of health and medicine. One is the study of the body in pain. One of the ideas is that the person who's suffering from particular illness or undergoing pain, it's very difficult to communicate the experience. So narratives have been used in a very big way to generate and make people talk about pain and illnesses, chronic and acute pains, and patient narratives have developed, become a very central part of medical anthropology, and they are juxtaposed against expert narratives. It's not just the doctor who can pronounce on a particular condition. What does a patient, a cancer patient, or a patient suffering from any acute ailment, how do they experience? So the study of study, I want to tell you that there's a very interesting study by Cecilia Holland. She's studied labor pain. She found that Indian women valorize labor pain. Even in Apollo and other corporate hospitals, they don't take, very few women take the injections to avoid the labor pain. They want to experience labor pain because that is very closely connected to the achievement of motherhood. Whereas in the US and to a great extent Europe, women would choose to take the medicines that will reduce the labor pain. So this is, she has spoken about this. There are also very other interesting things when we understand bodily experience of illness, is the relationship between the body and the mind. For instance, Kleinman is a psychiatrist turned anthropologist. He did studies in Taiwan and in North America. And he pointed out something very interesting, which all of us can also reflect upon, that he's saying that the Taiwanese, the language, it has a very rich vocabulary for somatic or bodily symptoms, but very weak vocabulary for psychic symptoms. In fact, he's saying many Asian patients, even in the US, let's say if they have an emotional problem like anxiety or fear, they would still use phrases like, I have butterflies in my stomach, I have a severe headache, I'm so stressed, so I have a headache. So even psychic emotional symptoms, they articulate as somatic or bodily symptoms. And there's the vocabulary, cultural, the languages, Asians, in the Indian subcontinent, is very rich in words for somatic symptoms. In my own fieldwork, I found at least 10 terms to describe different kinds of stomach ailment, from churning of the stomach, paining of the stomach, burning sensation in the stomach, pinching sensation. I mean, you can reflect upon your own language and see what are the whole ranges of bodily experience. So these how bodily experience is articulated, what are the linguistic tools through which it is articulated, and how in North America they have a richer vocabulary to articulate psychic symptoms. So patients come by saying, I have anxiety, I have fear. They clearly separate psychic and bodily symptoms. They have lesser vocabulary for bodily symptoms, but a rich vocabulary for psychic symptoms, says Arthur Kleinman. So it's very interesting how bodily experience is articulated. There are many studies on body and mind relationship, injuries, trauma, and adaptation, which sociology of health and medicine has dealt with. So I would think that body in medicine offers us a very fertile ground for study and for comparative studies, not just East and West or essentializing it. We should also look at differences between different regions within India, how, we'll have a very rich understanding of linguistic articulation of bodily experience, or within different parts of South Asia, etc. And I think we'll understand a lot about sociology. So the body is a prism through which we understand society. And it would be a very rewarding experience to adopt that line of inquiry.
So how do we distinguish between health and ill health, given the experience of disease and its detection, which is embedded in heavily social settings?
See, this is a challenging question for sociology. Okay, because like I told you, sociology has moved away from biology and the body. But sociology of health and medicine has brought the body and biology squarely into the discussion. And we cannot ignore the biological substrata by which we understand ill health or disease. But at the same time, not everything about disease or recovery could be explained by biology. There's a wide variation. And it was Stalcott Parsons who pointed out that between the onset of disease and its recovery, there are so many factors involved, including the willpower of the patient, the social support and care that the patient receives, apart from the medicines, that it's very difficult to attribute the cure only to medicines. So it is here that one has to look at, so ill health then comes under sociological inquiry. But I should point out right at the beginning that whereas ill health has been studied quite in detail, health is a more elusive phenomenon. In fact, Gadamer, he's got a book called Health as Enigma. It's very difficult to define and understand the concept of health. It's an idea. Ill health is something that medicine deals with, it studies, and it has a material basis. So I'll come to health later. But as for ill health and disease, Parsons made a very interesting intervention in the 50s when he suggested that sickness is a role. So what did he mean by that? He argued that how do people know that they are not well? In your daily life, what happens, if you are not able to perform the functions or activities that you were already doing, and to a point where it is disturbing you, then you suspect that you are unwell. Let's say you have a nagging headache, but you won't bother about it. You will continue to do things. But there's a point in time where the headache becomes unbearable. It prevents you from doing your normal activities. Then you decide, okay, I'm ill, something is wrong with me. So Parsons argued that illness is detected in everyday life when you are unable to perform the functions you previously performed. And the process by which you adopt a sick role. Okay, now you decided, okay, I'm sick. And you wait and watch, you try various things, and then you go to the physician. Because sickness or the illness experience has to be validated by an expert. I can't, let's say, for 1 month, say I have a headache, not get any treatment, and also not do my normal functions. Whether our institutions like family or workplace, they will not admit it. You need an experience, illness experience has to be validated by an expert who is normally a qualified physician who undertakes the tests and whatever it is. So in this way, ill health as something that emerges from our everyday, it gets defined as something where you are not able to carry out your normal function, and how you carry out and how you go about your sick role. How much do you withdraw from your normal life, and at which point do you return to your normal life, or do you return to a new normal in the case of chronic and acute ailments. So the understanding of ill health in sociology and in anthropology, medical anthropology, has been taken up at 2 levels. One is at the level of the individual. You have so many studies of many individual diseases, chronic patients, women, who are of different classes, they are suffering from fatigue, various conditions. Many studies are there. And you have, and here anthropology makes a distinction between disease and illness, which again is contentious. But what is the distinction? They say that the biological changes or lesions in your body, whatever changes are there, it is called disease. So you have a tumor or something like that, or there's a biochemical change, or there's a blood pressure increase, a physiological parameter is altered, which can be measured and understood by an expert, is disease. But the behavioral adaptation to disease is illness. And that is, so sociologists argue that illness is also important. It's not just the physician, he says, this is the disease, do this, do that. The moment there is a chronic or a severe disease, there are financial implications. An important person in the family falls sick, and then there's a whole change in the roles played by other family members. How much of caregiving is there? So how people behaviorally adapt to illness, how they take it, how they behaviorally adapt to disease is illness. This distinction is made in medical anthropology. As far as ill health at the collective level is concerned, there are several studies on social epidemiology, means looking at ill health at the collective level. And here the Marxists have an enormous contribution. Social epidemiology means it's how diseases are distributed in a population. And you'll be surprised to know that class plays a very significant role. If you look, for any country, if you see how diseases are distributed across the population, class and occupation play a very important role, why certain sections of the population have certain diseases and why others don't have it. So social factors do play a key role. You can see infectious diseases. In the Indian situation, even caste plays a role. If certain diseases that affect poor people living in unhygienic conditions, they are not attended as much as certain other diseases that get research and all that. So that kind of work is there. Lastly, I just want to tell you about health. I told you that health is more elusive, because if you think of it, health is, it's a state, it's an experience. Gadamer says you realize health only when you don't have it. When you're healthy, you're not aware of it. Only when there is a pain, ache, or a disease, okay, you realize that there was a state when this thing didn't exist. And it's an experience. It's also a value, and for many, it's an aspiration. So health is something that eludes quantification, though doctors want to, medicine tries to do it, and biomedicine fails miserably in this, because biomedicine is a curative system. It can restore, if you fall sick, it can cure you and restore a normal. But the normal need not be healthy. Let's say your blood pressure has shot up, and then it brings up brings it through medication to 120. That doesn't mean you are otherwise healthy. It has brought the blood pressure to 120. So health is as defined by the WHO as not just the absence of disease, but a state of, where mental and physical well-being, etc. Such a definition is coming from, I think, Sushruta Samhita. But, so it's very, biomedicine can return you to normal, but it has a huge curative value. But on health, it does not have a positive definition of health. It's health is the absence of disease. So health, how different cultures, how communities understand health itself, again, is a very interesting and intriguing study. Many studies have shown that people with chronic diseases consider themselves healthy because they have adapted well to the disease. It's not the fact that you're diseased that makes you unhealthy, but you adapt to the disease very well. Despite the pain, you carry out the normal activities, or you have accepted it and accepted a new normal. People consider themselves healthy. So in many interviews I've revealed, people considered as having disabilities think that they are healthy. So the subjective perception also matters a lot in health, and mental and physical health are both involved. And in these matters is where social sciences can play a very important role in understanding how different communities or societies understand health. So there we have a bigger role to play. And these are the kind of studies that address in health.
Right. Now, Professor Sujatha, there is also something called lifestyle problems. Right. Do you think the medical establishment is increasingly defining lifestyle problems as diseases and then medicating them?
Yes, there's a word for it. It's called medicalization. It was suggested by Ivan Illich long ago in the 70s. He's saying that actually the role of medicine is to treat people who are sick and cure them. But increasingly, medicine is getting into the life, it's colonizing the life of the people who are normal or healthy and doing things for them. So even day-to-day things like getting sleep, they say after 40, everybody should take vitamins or, fortify yourself. So much so that he said that in countries like the US, anybody above 40 might be taking like 3 or 4 pills. I mean, it's a routine thing. That you pop some pills or medicine, and this created by the pharma industry. So he said that medicine is producing an iatrogenesis. He's saying that suffering and pain have a certain role in life. Now, if you take painkillers for very small pain, I mean, medicine prevents people from experiencing their own bodies in an authentic way. That's what he said. Now, what is happening today is things are getting more complicated. When you say lifestyle problems are getting medicalized, very often governments have no other way but to adopt these use medical solutions to social problems. Say, take for example, malnutrition, the widespread anemia. It's caused by certain major shifts in food habits and loss of healthy food grains. But governments try to give iron syrup to the people. And when young girls consume iron syrup on empty stomach, they have other health issues. Rather than working on the nutritional food habits of the people, which is a whole, which is connected to agricultural produce, a whole range of other supply mechanisms and economic arrangements, a technocratic solution is done by fortifying rice or just providing iron syrup to people and trying to see if you can solve the anemia problem. This is called, this is where you say larger social issues and economic issues are being reduced through and compartmentalized through a technocratic approach. So there, this kind of lifestyle problem is this, but I have to add that sometimes medicalization becomes necessary because of our social predicament. Let's take mental health, for instance. if there is a mentally ill person who needs care and attention, families are increasingly not be able to give that. In Foucault, when he wrote about, in his book on madness in Europe in 18th-20th century, the emergence of the psychiatric institutions, it was happening so much that people could not care for the mad people, the crazy, insane people in the houses. Either they have to be abandoned, or so you need a place where in the emerging setup to give care to these people. So I noticed that when I made visits to the mental hospitals, I do take my students on field work, and in a couple of visits to mental health institutions in Delhi, one noticed that the mental hospital is no longer a sensational place like it used to be 30 years ago, 25 years ago, where people were chained or locked and shock treatment was given. And so a doctor told me, a leading doctor, that see, why do we need to restrain people physically when we can restrain them chemically? That means you can sedate them, so they will be calm and lying down. It's easy to manage them, give them some food, and it becomes manageable. So psychotropic drugs, for instance, they have gained a lot of currency today. It's common to see people taking tablets for depression or whole range of ailments. And they are spreading in a very big way, and especially for mild sleeplessness, etc. The worst thing is, in these mental health institutions, one noticed that children of 7 or 8 or 9 years who are hyperactive, considered hyperactive, they are given psychotropic drugs to reduce their activity. Maybe they are, it could be that the urban situation where the houses are small, a very active child cannot be sustained. So the energy of a young child becomes a mental, it gets designated as a hyperactivity or a mental problem, and gets treated through medication. So these are all, this I think is the greatest problem, the use of psychotropic drugs. It's a controversial thing, but it's also very convenient, because who will take care of the mentally ill? How many people can be admitted to hospital? So the family, the caregivers say, please give them tablets. So they can just sit, they can be maintained. They will suffer from side effects, etc., but it is necessary to deal with that. So medicalization also has, of lifestyle problems, also has its functions. And so it continues.
Right. And then, there is also this increasing privatization and corporatization of medicine that we are witnessing, or rather have been witnessing for some time now. Now, how has that impacted health?
Yeah, so see, privatization and corporatization, on the one hand, improve the quality of the medical services, tertiary services, they improve. So if you look at India, it is top 5 in medical tourism. Okay, that a lot of people come here for surgeries. Very high, good quality surgeries are performed. High level of skill is found. But at the same time, we are 195 in quality of care and access to the general population. Why is that so? Because we have an excellent private corporatized healthcare with the latest facilities for tertiary, secondary and tertiary. But at the primary level, access is really poor. So what happened, and this is not just true of India, if you look at US, which relies heavily on privatization, private healthcare, despite its insurance schemes, the Black populations have suffered from lack of access. It's been written about by Amartya Sen. In comparison to Germany and France, which have publicly funded health services. So all of us know, I would like to add and want to emphasize here that public investments are critical, not just in medicine, but sometimes in allied fields, will have a very good impact on health. I would consider public transport as an important factor which contributes to health status and to education. I did fieldwork in Madhya Pradesh to understand the access to health. And we find throughout India, and specifically in states like Madhya Pradesh, where public transport is abysmal. There's no public transport. Buses are very rare. Even private buses are few. Every house, even the village, owns at least 65% owns a motorbike. Now, even if you have government health facilities, how will people access them? Unless you have public transport. Other states in the south of India having the same amount of public health facilities but better transport, it translates into better health status because people can catch a bus and go and get themselves treated at when there's public transport. But in places where this is not found, people have to hire cabs, which itself is very costly. Or they have to, very sick people and laboring women have to be taken in motorbikes. And also the amount of bike accidents. India is one of the largest in crude death rates due to accidents, is increasing. So public investments, not just in medicine, most important is public transport. Only then people can access the medicine. And the privatization, it's a very big hit on private transport, like cabs or private other services, eat into the family's resources in a very big way. Then privatization can be seen at other levels of scientific research also. There's a beautiful book called Biocapital by Kaushik Sundararajan. He's saying how increasingly private companies, big, huge companies are engaging in pharma research or genomic research. And it's very difficult to say whether something is pursued for the sake of profit or for its scientific value. A particular course of thing, a medication or a course of treatment or a particular piece of research. So these are the kind of issues that give rise. And lately, traditional medicines have also entered the commercialization and commodification path. All of you know there's a very big market for herbal and traditional products. So those things that were the poor man's rich resources of health, which were part of daily, treatments, etc., have acquired commercial value, and they get commodified to become products. Millets, millet biscuits, etc. They have moved. These products, which were the poor man's rich food, have become the rich man's poor food. So you have Britannia biscuits, etc. These products are moving up to get commodified. So this is what is happening. And traditional medicine, unfortunately, in India is also following the path of privatization and not developed so much in the realm of public.
So, Professor Sujatha, how do we understand the effectiveness of cures when there are so many, contrasting and competing standpoints? How do we look at that?
Yeah, see, this is a very intriguing and challenging question for sociology of medicine, because when people thought of sociology of medicine, they said sociology cannot interfere in matters of efficacy and effectiveness. It is for medicine to decide. We are not experts in medicine. We are sociologists. We can study the cost of a treatment. We can study what is the doctor-patient relationship or the organizational features. We can study sociology of medicine, but not in medicine. But lately, the significant developments in sociology and anthropology have led to a problematizing the concept of efficacy and effectiveness of medicine. In what happens in biomedicine today is we consider a particular medicine or treatment efficacious when it has passed the randomized control trial, which is the gold standard. So it has to be set in abstract laboratory conditions where no variation is allowed, and on a representative population, the drugs are tested. Once that is cleared, it is unleashed in the rest of the population. But the transition, efficacy of biomedical drugs is tested in laboratory conditions, and it is assumed that those 2,000 or 2,500 people on which the drugs are tested is adequate for the medicine to be unleashed and sold and prescribed for the whole of the world. But this has, in actual lived conditions, this is causes huge problem. Lately, feminists have argued that most medicines are tested on men and are given to women. There is the same medicine works differently in the male and female body. Now, racial differences are there. And though the body is same and the anatomy is same, there is a whole big difference due to racial, genetic, and geographical factors, which medical science and testing itself has incorporated in the trials. But apart from that, clinically tested medicines need not be effective. You and I go to a doctor, we get treated for some ailment. Sometimes we are not satisfied, even if they prescribe a medically tested drug. So in lived conditions, the term that we use is effectiveness. A drug may be efficacious in the sense that it is cleared in the randomized controlled trial, in the laboratory conditions, but under lived conditions, it's often not effective. But medicine will not take this into account. They will say, okay, it's your variation, maybe it doesn't suit you, or you imagine something, you didn't take the medicine properly. So they will attribute it to individual and incidental factors. But that cannot happen anymore. Sociological studies have extensively documented the layperson's experience of medicine and medical treatments. There are beautiful, in fact, there's some anthropologists, they went, of reporting the same symptom to 5 different doctors. And they said 5 different cardiologists gave different prescriptions for the same symptom. So these kind of interesting studies have been done by anthropologists. And this reveals that there are different treatments for the same thing, and also that the cure experienced by the patient can be variable. So this gap between the lab and the life, there's a very big gap, and it needs to be studied by social sciences. And the patient's view of something, the patient might not find a treatment effective. What do they generally do? They pay the doctor and move to another doctor. They don't challenge this doctor that your treatment was not effective, and they can't do much about it. And sometimes patient, you can see hopping from hospital to hospital, etc., because a particular treatment did not work, even when it is given by the best of the doctors. So competing standpoints, effectiveness has been pitched as a counterpoint to efficacy, to say the patient's experience of cure is also important. Why? The disease is experienced by the patient. The knowledge of the disease is with the physician or the expert. Now, who will pronounce that the cure has happened? Does the doctor have the prerogative, or it is the patient? So these kind of questions brought up by social sciences on health have improved the rights of patients. It gives them both a legal right and it articulates the experience at the of lab tested medicines at life. So efficacy becomes problematized. It's not that it's just the prerogative of medicine or medical sciences. Then these studies have gained more complication, a complicated dimension when you compare different systems of medicine. How biomedicine deals with arthritis or hepatitis will be different from how Chinese medicine deals with it, or Tibetan medicine deals with it. And what counts as efficacy? Tibetan medicine doesn't have a notion of virus. It works on the host. So how these things are negotiated, what is the power dynamics? And the concept of epistemological violence has been foregrounded by scholars of Asian medicine to say how parameters of biomedicine are being imposed. But I'm very tempted to tell you one very interesting and hilarious study to tell you about how social sciences can completely bring a new perspective on existing mainstream things. See, I just mentioned to you that drugs are tested through randomized control trials. You have an experimental group, you have a control group. The experimental group receives the drug that is being tested, and the control group receives something known as a placebo. That is, it looks like the drug, but it is an inert substance. Nobody takes the placebo seriously. All of us are focusing on the experimental group. But an anthropologist, Moorman, he observed when he looked at clinical trials completed that in many cases, while the experimental group saw 80% recovering from the drug, from the placebo group, 50-60% recovered. It's very surprising. How can 60% of sick people recover just through a placebo? That means there's so much money that we are investing on the drug. Is it worth it? Why is the placebo also working? It should not work. It's an inert substance. And he also found that the placebo effect is greater in German and other populations where people are individualized and lead compared to more societies like Brazil and all. So he concluded that there's something called a meaning effect. That is, it's not the medicine alone that works. The fact that somebody is giving you a medicine, talking to you, etc., also contributes to the process of recovery. And so this is a very good example of how nobody pays attention to the control group or what happens to the placebo group. By unearthing all that information and looking at why placebos also work, Moerman has taken a different route to understanding healing, recovery, etc. And the very interesting and hilarious examples. Even they have tried sham surgeries, okay, to check the placebo effect. So they don't perform a surgery. Instead, the person receiving the surgery sees a video of the doctor. The doctor is going to do the surgery as playing a football match or something. And then subsequent day, there is a sham surgery. And then the patient recovers from knee problems. The patient doesn't know he received a sham surgery. So it's amazing. I mean, they have done the kind of studies that these people have drawn in to understand what is known as the meaning effect in recovery. So all this makes the process of effectiveness, efficacy under competing standpoints ever more interesting to research.
Right. Professor Sujatha, the relation between the sufferer's experience and the expert's medical knowledge is articulated as a core aspect of any system of medicine. Then how do systems of medicine address this issue?
This is something I discussed in my... We are going to compare different, no point in saying traditional, modern, and those are all not very useful. We have to look at what is the core idea of any medicine. You have a patient who is experiencing the disease, and then you have the physician or the expert of any system who has knowledge how to cure the disease. So what is the situation here? Patient has no knowledge of the disease. Physician has no experience of the disease. So in this situation, how different systems of medicine, who has power to, how the patient can gain an understanding of the physician's strategies, and how the physician can understand what the patient is going through. How different medical systems mediate this is a point of great interest, and that's something I've looked at in my work also. And in biomedicine, which is the dominant and one of the most widespread form of medicine, it is based on a very detailed understanding of body anatomy and its part. Biomedicine emerged from pathological anatomy and dissection of corpses. So it has a very precise understanding of knowledge, and therefore, if you look at the structure of the clinical encounter, physician and patient, the physician has greater knowledge and greater control over the process, because the patient just has to tell the symptoms. Then the physician carries out a host of tests. Now, with the advance of technology, even the physician's body is not required. You have telemedicine. It is enough if you send what are your parameters, physiological parameters, they prescribe medicines. They don't need the actual physical body of the patient. It has been dispensed with in many medical encounters. They just want your parameters or test results. So the body is reduced to some numerical parameters, visual images, specific organs that are affected. So it is an expert-centered medicine, and the expert has greater control. Now, if you look at Chinese or other systems of medicine, they start from the patient's symptoms. First, the patient has to tell the symptoms, and then they go and they have a system of expertise and classification to which they go. They also used the testing of the pulse and so on. I won't go into detail. Now, traditional systems are also undergoing transformation. Or if you look at homeopathy, for example, or Unani, for example. Homeopathy, for example, takes a patient's symptoms in great detail. They don't require these tests because homeopathy believes in vitalism, in that a very small dose of medicine is enough to address the problem. So it is the opposite of allopathy, which is heavily pharmacology centered. So therefore, homeopathy is not an expert-centered system. It's widely adopted because people feel very, comfortable talking to the homeopath and explaining the symptoms. Though it has been criticized as being a placebo, all the medical associations, biomedical lobbies have denied that homeopathy is a system of medicine. But people find some cure because of popular support. Even in the Western countries, homeopathy has been accepted in the NHS in the UK, and it's now become part of the insurance system and all that. In India, it's always been there. What I'm trying to say is the these expert-centered systems like allopathy tend to exclude the bodily experience. For instance, if you have a severe backache, a lot of working class women complain of backache. But if it is not reflected in any X-ray or any test, if there is no lesion in your body to which the ache can be attributed, then the doctors will say you are imagining it. It's your problem. It's your psychological problem, and they'll give you a painkiller, which will temporarily assuage the pain, but it might recur. So expert-centered medicine and technology-centered medicine requires tests to confirm the disease. It's not enough if you go and tell, I have a pain, I have an ache, I have this symptom. They will listen to you, but unless the test confirms it, they will not be able to treat. The rest, they will think you are imagining. They'll give you a sugar pill or something. But this is not the case with a whole range of other symptoms, which are patient-centered. They start with the patient symptoms and then bring their expertise to bear on that. So by using whether the patient symptoms, whether it plays an epistemic role in the diagnosis, we can distinguish between systems rather than calling primitive, modern. Those old binaries are not helpful. We have to see what is the asymmetry or this experience versus knowledge dichotomy within medicine, how it is mediated, I think is a very good access to understand medical systems. And I've used it extensively in my work.
You've also talked about how the understanding of health and health-seeking behavior should go beyond statistical indices. And I actually want to know, more from you on how do we look at whether statistical averages or lived experiences of illness and health, which is closer to the truth?
See, this statistical understanding of society and narrative understanding of society, it's a primordial question in the social sciences, isn't it? Durkheim and Weber are pitted against each other on this. The very same question comes into sharp relief in when you study health and medicine, health, because and this was reflected in a debate between Amartya Sen and Arthur Kleinman, an anthropologist. So whereas Amartya Sen thinks that you do need objective and quantitative indicators to measure health status of a population, Arthur Kleinman, he argued that, subjective perceptions of the people of their own health is more helpful and it's more meaningful. But Amartya Sen argued that subjective perceptions vary from place to place. So it is possible that women in certain rural societies will not talk about their disease, even if, let's say, they are having heavy menstrual bleeding or they have suffered from other ailments. They have been taught not to talk about it. So, whereas in certain other regions, women talk a lot about their health and bodily condition. So, we cannot go by what subjective narratives or pronouncements, but we should have an objective indicator because maternal mortality in those rural regions is very high. It does indicate that people are sick, they are anemic, they are undernourished, they don't get medicine at the right time. Because they don't talk about it or because they say we are healthy, can you ignore it? So I'm saying this debate is there in health also as to which should be taken. Many anthropologists have taken a position. Sometimes anthropologists and sociologists think that taking quantitative existing databases is not reliable. We don't know how the data was collected. So some of them go and collect their own primary quantitative data in order to get the data from the ground right there. And in this, I often recall the work of Nancy Shepherd Hughes. She was studying a shanty town in Brazil, and she thought there were too many children are dying, but this was not reflected in the official statistics. So she devised an ingenious method to find out how many children are dying. She asked around, people didn't talk about it. It's not something people talk about when kids die. So she went to the coffin maker in the town and asked him how many coffins for children that he made. So it's not quantitative versus qualitative alone. You can quantitative data at which level, statistical information, numbers at which level are we collecting also matters. So it is my argument, and I've argued repeatedly, that they should not be pitched against each other, but they should be used in a way that I call alternation. That is, you start with statistical data on something. It will throw up certain questions and anomalies. Then you can use that and you do a closer micro level qualitative study. You will understand how whether the problems or the issues or gaps highlighted by the quantitative data is actually present in the existential context of the people that you are studying. So there are then by doing this, but the qualitative data will give you the actual context, reasons why people do or do not do certain things. Then you can go back to the quantitative data. So I think we should be alternating between these things, and by doing so, we can get a better handle over truth. So truth does not lie in statistical indices or in narratives. These are just methods by which we understand reality. Truth emerges when the researcher puts to good use both these methods, uses one to juxtapose the findings or the anomalies coming from one source with the other. People call it triangulation, but I call it, I want it to be very actively, intertwined even in analysis. So you move from quantitative, qualitative, and at different levels, from the macro level, district, etc., and to the micro situation, collect first-hand data. And such an approach has many possibilities. So I wanted to sum it up by saying truth lies in the effective use of both these methods.
I think that's a very important point, Professor Sujatha, and that also brings us to a final question for you, which is that how does the ethnographic approach contribute to the study of health and society? And could you also talk about it by using a few examples from your own work?
Yeah, see, ethnographic method is one method that takes you directly to human meaning and values. I mean, and it yields very rich data. It has been seen by many, if you take a Gandhian approach to ethnographic field work, it's been written about, then it is one way in which you can develop a relationship with the other, whomever you're studying, the object of your research can become another subject and a co-traveler in your life. It's a way by which you can get exposed to the life of other people. And especially in today's life, where we are all like cocooned and we are watching, the world through media. Ethnography is also a healing mechanism, and it improves social equality. If we actually go live, see how people lead lives, how they solve problems, etc., and so on. So it's a very significant method. Scholars like Veena Das have argued that ethnographers are witnesses to the social suffering of the people. That's how. We have to document people in the lower end of the social hierarchy, or people who are, suffer from destitution and deprivation, etc. And we bear witness to what they call social suffering. Of course, ethnography has been used extensively in numerous other contexts, not just to study the poor and disprivileged. But like I told you in the beginning, it is one method that can give you, direct access to meaning, values, and culture in a very significant way. In health studies, I think we use it significantly. In my own work, I used it to understand the problem of food and eating, which is often summarized by economists or biologists as nutritional status. If you see, why are economists so concerned and bothered about nutritional status? They see it as part of a human development index. But economists see food only as a thing or a commodity in terms of the price of food. On the other hand, the nutritionists who are biochemists see food as a thing consisting of certain caloric value, so much proteins you should have, and all that. And these approaches have not, this kind of restricted approach has not borne fruit, because if you see, the biggest puzzle they are posing is despite the drastic economic growth witnessed by countries like India, the nutritional status of the population is very bad. It's not improved with this kind of increase in incomes. It's a puzzle. The puzzle of malnutrition among growth is Jean Rhys' article. It's almost 15, 20 years ago he wrote it. And people are trying to find out why this is happening. But they are looking at aggregate national level statistics and making generalizations. Why despite economic rise in income, it's not matched by improvement in nutritional status. But when I actually went and did fieldwork in certain villages, I found that families, households where the income is increasing and where education is improving are the ones where women suffer from malnutrition. This quite goes against the mainstream understanding that increased income and education will improve nutrition. Why this is happening is because people don't acquire capabilities in a linear way. You have little more income, little more education, then you have better nutrition. No. People, in order to achieve education, people forego food or nutrition. Girls from rural areas travel long distances to attend colleges or to take employment. And they just carry one tiffin box of some rice or some roti, etc. So though family income has increased, and though the education level has increased, the nutritional status will fall, not because they don't have money to eat, but simply because there are no good, healthy food options available for people who are away from home. for a long time, and who don't have that much money to buy healthy food or things, they are the working class or just above the working class, which is where the nutritional decline is noted. So this becomes evident when you go there, see and talk to people. You observe what are the changes in the eating habit. Not all malnutrition problems are caused by monetary reasons, but they are caused a high level of domestic violence. Also, a lot of women deprive themselves of food when they face domestic violence. And there is alcoholism among men leads to anemia among men. It's not just a problem of the women. And lastly, I wanted to foreground that we can't think of food merely as a thing or as a commodity as these people have been seeing. We are sociologists. There's so much of good work on food and eating, but we have to bring it to bear on nutrition studies and have a dialogue with the economists and say that food is not just a thing, or people don't, it has many functions. Your daily food may be conditioned by cost and other factors, but there's something called aspirational food, food that people want to consume. When I did interviews in South Africa of labor in orchards, they all told they eat very cheap meat and suffer from overweight. But they told me if we had the money, we would like to eat fruits and vegetables. They are very costly there. So every different class and communities have their own aspirational foods. Maybe the elite in Delhi want, or in any part of the globe, want to have vegan food, or they want to have a natural food, means without pesticides and fertilizers. But someone else, they might want to have a Dalit household might want to have white rice because they have been denied white rice. They ate millets all along. And for them, white rice and ghee or, good food means not millets. If you ask them to eat millets, then it's like a stigma or a decline in social status. So we cannot, so by simply promoting millets, etc., we have to understand the social dynamic and the value of food, aspirational food. Then people have indulgent food. That is, they know it is unhealthy, but there are occasions where you feel like eating that. So I classified it into everyday food, ceremonial food, aspirational food, and indulgent food. And if you compare communities or classes, strata of people, as to how much of their plate consists of these things, then you will understand, because when they report to economists and to nutritional scholars, people often will not report the indulgent food. They would have had to some oily stuff, but they treat it as a snack. They may not report it, or they don't report if they consume buttermilk. But so what people report also varies with the kind of questions that are being asked, because we don't remember certain kinds of food we eat, or we don't think it's worth talking about it. So the nutritional status, the understanding of nutritional status has suffered because of a quantitative and a restricted approach. And here I think ethnographic studies on food should be brought to answer some of these questions. There's a very rich body of study on food and eating in India, but that has not been utilized to understand a public health problem like this. So I would think that it could be used fruitfully for policy making.
Well, thank you so much, Professor Sujatha. This has been such an enriching conversation, and especially listening to you after some years, it's been quite fun for both of us. And thank you so much once again for joining us on Doing Sociology.
Thank you so much. It's a great forum, and it's my pleasure to share my thoughts in this forum. Thank you so much.